I'm Martin Gerdes. I live in Old Westbury, New York. Head of biomedical sciences there at New York College of Osteopathic Medicine. I've been looking at the effects of low thyroid function in heart failure for a number of years, and it's clear that there's a growing body of evidence that this is a major problem. In fact, if you look closely at the literature and the serum values in some of the studies, that predicts as much as 90% of patients with heart disease may have low thyroid function, at least in their heart. Now, why is this important? Because low thyroid function eventually can cause heart failure. We made rats hypothyroid in a study published in Circulation in 2005, and eventually they died of dilated heart failure with no other problem, but just chronic hypothyroidism. So I think the question we should be asking is how much of heart failure is due to a hormone imbalance at the cardiac tissue level that we're overlooking. Because if you look at a cross-section of cardiology patients, you'll see that about 20% have overt hypothyroidism, another 10% have sick euthyroid syndrome, and another 30% have low T3 syndrome, and there's hardly any patients left in the upper half of the normal reference range, according to a study by Giorgio Ravasi in Circulation in 2003. And I think that this is commonly what I hear from other cardiologists. But we're afraid to treat these patients. Why are we afraid to treat? Because there's studies that show that thyroid treatment of cardiac patients can lead to increased arrhythmias. However, low thyroid function causes arrhythmias too. And I think that we should be looking at that issue, that since their studies have shown that subclinical hypothyroidism actually promotes arrhythmias too, and it's more likely that most of our patients have some borderline low thyroid function rather than high thyroid function. Again, we've actually identified cellular mechanisms of this. Low thyroid function promotes a maladaptive change in the shape of myocytes and abnormal remodeling the chamber. It actually leads to impaired coronary blood flow, and mainly through a modification of the small resistance vessels. We found dedifferentiation of the smooth muscle in the small resistance vessels, which is correctable within 3 days of thyroid treatment. I think that the question we should be asking is how much of the heart failure is due to the underlying disease, ischemic cardiomyopathy or non-ischemic idiopathic, and how much is due to a superimposed low thyroid function that is actually indistinguishable. Heart failure from hypothyroidism is indistinguishable symptomatically, really, from heart failure of other etiologies. And what our animal data are showing is that with hypertension and ischemia, the heart actually makes itself hypothyroid by activating enzyme, a D3 deiodinase enzyme that destroys active forms of thyroid hormone, both T4 and T3. So here we also have a potential that treatment may only cost about $2 a month. And it's a very low-cost way to potentially dramatically impact heart failure outcomes. What we need are clinical studies that actually show what therapeutic doses. We've had several studies that have shaped the mindset of practicing physicians, but they're largely toxic doses of thyroid hormones were given, or analogs were given. And all the studies that I've seen on short-term treatment of heart failure patients with therapeutic doses of thyroid hormones that didn't increase heart rate, for instance, show beneficial effects, improve exercise performance and improve LV function, and actually reduce depression and reduce neurohormonal activation. So I think that there's a growing body of evidence that suggests that this is low-hanging fruit. We really should look at this more closely and see what potential damage that low thyroid function is doing to cardiac patients, and particularly heart failure patients, and to determine what the effects of using a therapeutic dose, not a toxic dose, because we know too high and too low is bad for the heart, but a therapeutic dose, what effects does that dose have on a long-term outcome of cardiac patients?